Good afternoon, everyone, and welcome to the Trusted Exchange Framework and Common Agreement Draft 2 Q&A webinar. My name is John Randcourt. I'm the Director of the Interoperability Division within the Office of Policy at ONC and part of the broad team that works on the Trusted Exchange Framework and Common Agreement activities. Those colleagues are with me today to answer questions from the public. Why don't we begin? And so our agenda today is to go through an introduction of our speakers that we will have on the phone, and then an overview of some housekeeping items, and then provide an overview of the Trusted Exchange Framework and Common Agreement, and then have a Q&A session. So, today we have on the call listed here, first, Elise Anthony, who's the Executive Director of the Office of Policy. We have Zoe Barber, who's a Senior Advisor in the Regulatory Affairs Division in the Office of Policy. Alex Contour, a Public Health Analyst in the Standards Division of the Office of Technology. Morris Landau, who's a Program Analyst in the Regulatory Affairs Division in the Office of Policy. Mike Lipinski, who's the Director of the Regulatory Affairs Division, Office of Policy. Beth Myers will be on, who's the Deputy Director of the Office of Policy. Steve Posnack, the Executive Director of the Office of Technology, and then myself. As a housekeeping item, this webinar is being recorded and will be made publicly available after at www.healthit.gov/TEFCA. All phone lines are going to be muted during the presentation, and if you have questions, we ask that you submit them into the chat box. And we ask that you start doing that now, as we will enter into a brief overview of the Trusted Exchange Framework and Common Agreement. So why do we have the Trusted Exchange Framework and Common Agreement? It really started with the problem of interoperability, which so many of you are familiar with. But as a simple way of describing it, we have computerized our healthcare system, but those computers don't talk to one another. Congress recognized this and passed the 21st Century Cures Act, which took many steps to address the problem of interoperability, including information blocking and APIs, which we have addressed in a separate rule from TEFCA. But Congress also included in Section 4003 a demand on ONC that we develop or support a Trusted Exchange Framework and Common Agreement. And this is to address the network-to-network exchange of interoperability. We released our second draft of the TEFCA on April 19th, and we released a second draft because we really want to make sure we get this right. We want to have as much input from the public as possible in order to ensure that interoperability works for the entire nation. And what is TEFCA, or what are the various parts that are associated with it? Well, to start with, let's just explain at a high level that TEFCA will address that variation in network policies that prohibit the exchange across networks. And so that includes things like governance, security standards, exchange purposes, et cetera. TEFCA also includes, as part of it, a trusted exchange framework, which are those principles that drive how these policies are determined. It's important to note that we are not trying to supplant the success of exchange that's taking place, but rather we want to level the playing field, remove gaps, and ensure that information is moving. I'm going to talk for a second just about the structure and format of TEFCA, and start with the documents that make up the policies that drive TEFCA. So there are a couple different parts here that we have laid out in our informational webinar that we recently put out, and all of this material, again, is on our website. But the first part is the minimum required terms and conditions. And these are those terms and conditions that address the areas of variation between networks. We had done a fair amount of research to look at what is happening in the world of exchange right now, and really found that there were certain areas that were that had variability and needed to be defined as a baseline or rules of the road that everyone would have to follow. And that includes things like exchange modalities and privacy and security requirements, et cetera. Also, as part of the future common agreement will be additional required terms and conditions, and these will be developed by a recognized coordinating entity that will be serving as the entity that will operationalize the common agreement. So developing it, implementing it, updating it, and so on. They will also be updating another part of the TEFCA, which is the QHIN technical framework, and this document will be providing those technical requirements that operationalize the network. That recognized coordinating entity that will be serving as this governance entity is actually an entity that we heard from the public very clearly should be a industry-based organization, someone that has experience in this area, and a nonprofit entity. And so we have established a notice of funding opportunity for that recognized coordinating entity to enter into a cooperative agreement with ONC. We held a webinar on that NOFO very recently, and we asked that everyone on the webinar please do consider the requirements that we have put into that NOFO for the RCE, and very importantly, if eligible, we encourage entities to apply. I do want to take a couple minutes to talk through just a couple parts of the TEFCA that are highly relevant for so many of our stakeholders, and that includes the exchange modalities that will be enabled by this network of networks that we're creating, and that includes 3 different exchange modalities. The first is a broadcast query, which you can think of as Go Fish, where you do not know where the data resides, and thus you enter a query into the network. It fans that out and pulls back the data if it is in the network. The next is what is called targeted query, and this is when you know where the patient data resides and can direct a query to a particular location. And then thirdly, and this is added in the second draft that we released, which is message delivery or push. And this is when one wants to push particular data to another location. We heard very clearly from the public that this is really important for care coordination and public health use cases. Trust Exchange Framework takes a strong approach towards privacy and security protections, and I'm just going to touch on a few highlights of that, and that includes requiring that those qualified health information networks that make up the core aspect of Exchange in the TEFCA Exchange network must abide by HIPAA privacy and security as if it would apply to all of electronic health information. And when we say that all of electronic health information, we're using a broader definition than that in HIPAA, but nevertheless, we are complementing HIPAA with all of the approaches that we're taking here. Also on privacy and security, we have identity proofing and authentication requirements that are aligned with industry standards. We have breach notification requirements that build on HIPAA. We have a provision called meaningful choice, which allows individuals who do not wish to have their data shared by the network to be able to choose to not have their data exchanged via the network. Lastly, for this to be successful, we want to really emphasize that we need to work together with the stakeholder community and offer many different opportunities for input. Hence, we are having this webinar today, and we are seeing those questions that are starting to already come in. Thank you. Please do continue to submit them via the chat button. But also, please do submit formal comments via the ONC website on the MRTCs and the QTF. And again, if you are eligible to be the notice of to possibly be the recognized coordinating entity, please do apply. So for our format today, we're going to start with some questions that we've previously received, and then move on to other questions that folks are putting into the chat, and we're going to try and answer those the best that we can. So first, I am going to turn to my colleague Zoe and ask a question that we have received a couple times, which is, how does the TEFCA interact with applicable state law or federal requirements, and how is TEFCA aligned with HIPAA?
Sure, great question. So we designed the Common Agreement to be inclusive of all different types of stakeholders, including those that are HIPAA covered entities and business associates, as well as new and emerging technologies such as smartphone apps that may not be covered by HIPAA. And we are aiming in designing the TEFCA, we are aiming to create an ecosystem where everyone can play by the same rules. So that means that we had to take into consideration differences between the regulations that govern many of these different types of stakeholders. And so first and foremost, the Common Agreement aligns with and complements applicable law, including the HIPAA privacy and security rules, as well as any other federal or state law. All covered entities and business associates that are participating should be complying with HIPAA. And we even state in the Common Agreement, and you can find this in the definition of Common Agreement, that the Common Agreement does not and should not conflict with applicable law. And in the case of any conflicts with applicable law would take precedence. So then in other areas, in certain places of the MRTCs, we add an additional layer of protection that goes above and beyond applicable law. So, for example, and as John mentioned before, where HIPAA only applies to protected health information, the Common Agreement covers a broader set of information known as electronic health information. In other places, we mirror certain HIPAA rules to apply to non-HIPAA entities that have voluntarily signed on to the TEFCA. So, for example, we require everybody that is participating to abide by the minimum necessary rules in HIPAA when they're exchanging data. We also require that anybody who provides individual access services provide individuals with a written privacy summary describing their privacy practices. It's very important to us, and as we were writing the Common Agreement, it was extremely important to us to strike the right balance between improving access to the electronic health information that's available, but still ensuring that data is exchanged through the network in a safe and secure way so that participants can feel confident and trust the data that's exchanged through the network. So we would love to hear your comments on how we did in terms of striking that balance, and what, if any, additional privacy and security protections should be placed on participating entities.
Thank you, Zoe. And can I ask a follow-up, which is a very similar question that we've received? How does this apply to consent?
Great, yeah, so specifically, the MRTCs in sections 6.1.4, 7.4, and 8.4 lay out that if, and to the extent that applicable law requires an individual consent or approve the use or disclosure of their information, then whoever it is that has the direct relationship with the patient, whoever is providing the services to the patient, is responsible for obtaining and maintaining the appropriate consent. So, for example, if a patient goes in to see a doctor in an opt-in state, and that doctor is a participant of a QHIN, the doctor would be responsible for obtaining and maintaining the consent. We also require, and John touched on this before, the MRTCs requires that any QHIN participant or participant member that's providing individuals with services provide the individual with the opportunity to exercise their meaningful choice to request that their EHI not be used or disclosed via the Common Agreement.
Thank you, Zoe. The next question, I'm going to take this one, which is we've received several questions about the RCE and the NOFO, and I'm not actually going to answer those questions here. And instead, I'm going to start by answering, what is the RCE, and then explain why we're not going to answer questions about the NOFO. So to meet the goals of the Cures Act and really build on what industry has done, we've got a lot of public comment that favored ONC's approach that we proposed in the first draft, that the RCE be industry-based, and also a lot of agreement that it should be a nonprofit, neutral entity that is broadly trusted, transparent, free of conflicts of interest, and can ensure a level playing field. We do ask that folks review the NOFO for all descriptions of requirements of the RCE, and that if you have questions about those specifics, that you email those questions to us at tefca.nofo@hhs.gov. We are not answering questions about the NOFO on this webinar in order to ensure the integrity and fairness of the selection process for the RCE. Those questions and answers will be posted to healthit.gov. Some are already posted there. And we did hold an information session on the NOFO, which can be accessed via healthit.gov/TEFCA. Again, please do consider the application, and if you're eligible, please do apply. Application period is going to be open until June 17th. Thank you for the question from the chat as what is a NOFO? This is a acronym-free zone, so if you have questions on acronyms that we put out there, apologies. NOFO is a Notice of Funding Opportunity. And so this is the document that specifies the requirements for the recognized coordinating entity that we would enter into a cooperative agreement with for developing, implementing, updating, and maintaining the common agreement. Thank you for the question. Our next question, I'm going to turn to Alex. Alex, what is the plan for ONC on pilots?
Thanks, John. So I believe this question is probably in reference to some language in the Cures Act, which calls on ONC to provide pilot testing or provide for pilot testing of the Trusted Exchange Framework and Common Agreement. That specific section of the Cures Act also states that ONC can delegate pilot testing activities to independent entities that have the appropriate expertise. So we don't have any near-term plans for pilot testing. However, we do look forward to working with the industry and then NIST, which is also referenced in the Cures Act language, on pilots once QNs actually start to exchange live data under the TEFCA.
Thank you, Alex. For the next question, I'm going to turn to my colleague, Mike Lipinski, and that is, what is the relationship between TEFCA and the recent ONC rule?
Thanks, John. I think that's multi-layered. So I'll try to start the first piece, which is the rulemaking focuses on two key components to improving interoperability. One is requiring developers who participate in the program to have technology that will support interoperability, particularly APIs, using standard-based approach. The other piece is the information blocking. So there you're talking about developers who get products certified to this new API functionality. Then that's going to get rolled out to providers that are required to use certified technology in certain payment programs or other incentive-based or grant programs that the department or other parts of federal or even state governments require use of. Okay, so those would be the entities using that functionality. Comparatively, TEFCA is a structure for exchange between entities that would not be using certified LIP. So that's one distinction I want to draw out. Another one is the approach to getting that information. So through TEFCA, you could be looking at a broadcast query, being able to pull information from multiple providers at once or other entities participating, versus API could be just whatever endpoints that you're able to connect to get your information from that provider. So that's just kind of more of a broad look at like what the support is there. There's also, there's no requirements other than for your API in the rule for security related to like OAuth use. But they're beyond that in terms of security requirements in TEFCA that are proposed. Some of the other relationships, well, it's the use of the standard. For example, the US CDI. That standard is proposed in the rule, the Cures Act, for developers to be able to support its access, exchange, and use for certain functionalities that they get certified. Also, the same standard for TEFCA. To other terms, we use the terms EHI and HIN and define them similarly, both in TEFCA and for information blocking purposes. So you should be aware of that. The other key piece about TEFCA, at some point, we will be looking at rulemaking to establish a process for health information networks that voluntarily adopt the TEFCA to test to such adoption. That is not in this rulemaking, this Cures rule that we have out now. So I want to just be clear about that. But what is in this rulemaking are two pieces where we are trying to get your initial thoughts, the public's initial thoughts about how TEFCA fits into both certification and into the information blocking framework. And so these are called request informations. The first one is for developers that are participating in the certification program and are certified to what are essentially interoperability-based criteria. And then they also provide services for the connection to a HIN. So that could be either routing the EHI or responding to requests for EHI from a HIN. We're asking, should they be required as a condition of certification to participate in TEFCA? Now, again, this is to try to get your information, early thoughts on this, but this would inform a future rulemaking in which we would have to propose that type of requirement. Then on the information blocking side, we're asking, should there be an exception to information blocking for complying with the common agreement? So will there be certain things in the common agreement that it would be appropriate to give an exception to info blocking? So whether that may be something where it wouldn't fit under the fees structure, the reasonable cost incurred that we're proposing exception, that there are fees that would drive TEFCA participation and are necessary that may not necessarily comply with the reasonably cost incurred. So we're trying to get initial thoughts on that, but again, we would use that information to make any potential future proposal. This is nothing that would be finalized in the final rule for our current rulemaking. So I think that runs through some of the key connections. Hopefully that answers some questions.
Thanks, Mike. Thanks, Mike. For our next question, I'm going to turn to Zoe, and this question is, can an HIE or an EHR company or registry be a QHIN?
Sure. So in terms of the requirements to become a QHIN and who's eligible for a QHIN, we don't specify particular examples or types. First and foremost, you have to meet the definition of a health information network, and that is the same definition that we released in the NPRM. And then there are some additional prerequisites on top of being a health information network in order to apply to be a QHIN. So the health information network should already operate a network that provides the ability to locate and transmit electronic health information between multiple persons and or entities electronically. Such persons and or entities should already be exchanging electronic health information in a live clinical environment using the network. And what we mean when we say live clinical environment is, we want to make sure that the entities that are applying, are not just in the planning stages or still beta testing their exchange, but ensuring that they have the right infrastructure and personnel necessary to be able to meet the requirements of the common agreement. The third prerequisite is that the health information network should provide reasonable evidence that the exchange occurring on their network is in accordance with applicable law. And then they should provide a plan to the recognized coordinating entity in writing on how it will achieve the applicable requirements of the common agreement and the QHIN technical framework. And again, this is because we want to ensure the success of any QHINs that are going to be exchanging data live on the network, and make sure that that QHINs are able to operate efficiency and minimize failure. Once QHINs have been designated, if the possibility of them failing could have very detrimental effects on the market, especially, if they've already signed on participants and participant members. So, part of the prerequisite of providing that plan in writing to the RCE is to try to avoid against the possibility of that failure.
Thank you, Zoe. For the next question, I'm going to turn to Alex. How did ONC select the standards that are included in the QHIN technical framework?
Sure. So I just want to start answering that question just by reminding everybody what the QHIN technical framework is and what it intends to do. It is represents the technical and functional requirements to enable interoperable health information exchange between QHINs. So really, in sort of layman's terms, it's the pipes through which all electronic health information is going to flow between QHINs. From a legal perspective, the QTF is going to, or the QHIN technical framework is going to be incorporated by reference in the common agreement. And this basically just means that all health information networks that are attempting to become QHINs are going to have to implement the technical framework and the requirements in the technical framework. I will note that this also means that the QHIN technical framework is a separate document. It's not actually part of the language of the common agreement itself. And the reason that we did this is because we received a lot of public comment on the inclusion of standards and technical specifications in the first draft of the TEFCA. And we wanted to be able to have those standards change and evolve as needed as the industry changes and evolves without having to disrupt the legal side of things. And so basically this just means that QHINs won't have to re-sign the common agreement every time a standard in the QHIN technical framework changes. In this latest package of materials that we released, we did include a first draft of the QHIN technical framework. And we just want to be clear that this represents just an initial set of proposed requirements. At this point, we certainly don't expect that everything in the QHIN technical framework is going to be binding on QHINs going forward. And that's because the RCE is going to have a lot of flexibility to actually make changes and updates to the QHIN technical framework based on public comment and other feedback that we receive. We really wanted this first draft of the QHIN technical framework to start the discussion about the technical and functional requirements for QHINs under the TEFCA, and to help generate some of that feedback the RCE can consider before they actually update and finalize the technical framework. Additionally, as health information exchange standards mature, as I mentioned earlier, and the industry innovates around them, we'd expect that the RCE would modify the technical framework in the future to potentially include new requirements. And then the last thing I want to note, I believe there was a question in the chat about APIs versus IHE document exchange. One of the things that we were looking at when we were considering standards for the QHIN technical framework are things that were already used and implemented by information exchange networks today. So we can move as quickly as possible to production and scalability. And so you'll see less of an emphasis on the API side of things, more of an emphasis on the IHE side of things. Of course, this is all subject to change based on comment and the work of the RCE.
Thank you, Alex. Yeah, there's been quite a few questions on technical aspects, and I think I'll come back to you with some of those in a bit. Next question, which we've received variations on, is what are the benefits for providers? And I'm going to tackle that one, which is that really, if you think about it, providers right now have to join multiple data sharing networks that do not connect with one another. And this is burdensome, costly, and has potential negative results for patients. So when the common agreement is active, providers will be able to join one network and have access to the data on the patients they serve, regardless of where those patients went for care. So this is eliminating those one-off and point-to-point interfaces that providers are required to enter into right now. This allows for more safer, more effective care and better care coordination. Also want to mention that the benefit for providers and health systems will be that there'll be more easily able to connect to third parties such as analytics providers or care coordination services, HINs, QCDRs, other registries. Obviously, ensuring that appropriate business associate agreements and other arrangements are in place between those providers and their service providers. Our next question is going to go to Zoe, and is we've received a couple questions on pricing and fees, and so I have a question for you, Zoe, which is, what fees are QHINs allowed to charge?
Sure. And so first thing to clarify is that the MRTCs only deal with fees between QHINs. So, there's nothing in there about membership fees within a QHIN network, or fees between the RCE and the QHINs. So what we say in the MRTCs is that, first of all, QHINs, if they charge fees to another QHIN, there's nothing that says that they have to. But if they do, they should use reasonable and non-discriminatory criteria, or RAND criteria, as many of you may have heard before from the NPRM. QHINs may not charge another QHIN any amount to exchange EHI for individual access services. And QHINs may not impose any other fee on the use or further disclosure of the electronic health information once it is accessed by another QHIN. Any additional requirements around fees, including, how, the RCE will monitor compliance with these fees, and how they will, determine specific things around, what's reasonable and non-discriminatory. Those will all be specified in the additional required terms and conditions that will be developed by the RCE and approved by ONC.
Thank you, Zoe. Next question I will tackle, which is, can a particular entity join a QHIN? We've heard different variations on this, and so I want to answer this in a broad way that gets at those. And the answer is that TEFCA is generally inclusive of all types of participants. Really, anyone may voluntarily sign on to the framework agreements and participate in the network. However, they have to meet the requirements of the common agreements and the framework agreements. And we do want to be clear, though, that for most exchange purposes, participation is limited to covered entities and their business associates. Next, I see, first let me just clarify for someone, I want to make sure that we are trying to avoid acronyms, and I've had a couple questions of what is the RCE? Again, that's the Recognized Coordinating Entity, and that's the entity that will be developing, updating, implementing, and maintaining the common agreement, which is that document that will govern exchange and governance among the health information networks that make up the TEFCA ecosystem. We do have, we've also received a question that how will ONC be involved in the work of the RCE? And I'll tackle that as well, which is to say that we are going to work very closely with the chosen RCE, the RCE that's selected through the competitive process that we are undergoing right now, and enters into a cooperative agreement with that entity. So we'll be continually involved in the implementation of the common agreement. But I want to make clear that for the minimum required terms and conditions that bridge the differences among data sharing agreements right now, ONC will be the author of those, and ONC will approve the final common agreement. Next, we've also received a couple questions about what is the value proposition of being a QHIN? And for that, I'm going to turn to Zoe.
Sure. So I think it's important to remember that QHINs will be operating on a nationwide scale, and they must have the technical capabilities to connect together disparate health information networks and exchange large volumes of data on a daily basis from across the country. They're the gatekeepers of all of the electronic health information that flows across the network, and so they have really important responsibilities to operate efficiently and securely. Becoming a QHIN may not be the right thing for many entities. And those that decide to apply should consider the responsibilities of being a QHIN and make sure it aligns with their business model. Now, that being said, if being a QHIN does fit into your business model, and there are many networks that operate today, which it would likely fit in, then you would have access to more electronic health information and could have the opportunity to provide value-added services like provider directory services or patient matching services to the members within your network. And you would also have the opportunity to compete with other QHINs on a level playing field for more members or a larger percentage of the market share. It could also give entities that might be smaller or who don't currently have a large percentage of the market share or access to as much electronic health information, the opportunity to compete with other QHINs, based on the efficiency and quality of the services they provide, and not just, on how much data they hold. But again, it's important to consider, when you're thinking about how you want to participate in this network, whether it be a QHIN, a participant, or a participant member, what fits in with your business model and the needs of the patient population that you serve.
Thank you, Zoe. For the next question, I'm going to turn to Alex. Alex, what are the benefits to the public health community of TEFCA?
Sure. So first and foremost, I just want to echo something that you said earlier, which is that TEFCA is designed to be inclusive of and valuable to all different types of stakeholders, and that certainly includes public health agencies, state Medicaid agencies, et cetera. And one of the things I'll note is that in response to public comments, we did add QHIN message delivery as one of the exchange modalities that must be offered by QHINs under the Trusted Exchange Framework and Common Agreement. And that's because we recognize that a lot of the information exchange that's occurring today is actually push-based, particularly for activities like public health reporting. And so, we expect that TEFCA will provide a lot of overall benefits to the industry. Things like the increased availability of electronic health information and having an on-ramp to interoperability. And we think those things are going to benefit public health as well. And then some more specific, examples or use cases for public health is that we think that the public health agencies can leverage the network that's enabled by TEFCA to receive or share immunization records, data like case reports, syndromic surveillance information. Public health agencies could probably also use data from TEFCA to identify at-risk populations, to do things like disease surveillance and tracking the progression of outbreaks. So again, a lot of these benefits apply to all stakeholders as well as public health and help them meet their use cases.
Excellent. Thanks, Alex. So building on this, we'll take the next question, which is about what are the benefits of TEFCA for health information networks? And I'll start out by framing that TEFCA has the goal of building a single on-ramp to nationwide connectivity, and that means access to more data for the patients that those networks serve. I want to reiterate things that Mike had said, which are that there are 2 requests for information in the Cures Act proposed rule on whether TEFCA should be a condition of certification for developers and whether complying with common agreement should be an exception under information blocking. I also want to make clear that HINs can build on the common agreement to create valuable services for the unique constituencies that they serve. So this allows for additional business models that health information networks may be engaged in, provided they do not create conflicting legal agreements. The local solutions that are going to be made possible by this national baseline of TEFCA are also important to emphasize. That includes things like local provider directories, patient matching services, consent management services, and other activities that can support, for example, value-based payment models. We are seeing quite a few networks that are doing those types of things right now. Lastly, we want to talk about the fact that we see a lot of potential for HIEs to grow, and in many different ways. And one of those is expanding into community information exchanges. So the next question, I am actually going to pass back to Alex and Steve to refer to one of the technical questions that had come in, which was on query versus targeted queries, and broadcast versus targeted queries, and if there are requirements placed in the QHIN technical framework on, or limits placed on what types of queries can be made over the network.
There are no limits in the QHIN technical framework as of yet. Again, we have proposed use of the IHE document exchange-based standards. And so we would expect that the RCE might have requirements or certain service level agreements to help manage network traffic over the network enabled by TEFCA.
Thank you.
Yeah, this is Steve. Just one other thing to add. You know, as part of the context here, we have a mix of both policy and technology. And so when you consider what limitations there may be for broadcast query or targeted query, they still would need to fit within the broader policy parameters that the minimum required terms and conditions spell out, which would be the exchange purposes that were permitted to, to be conducted, through the trust exchange framework and common agreement. So that's just to echo kind of Alex's point with a bit more context.
Thanks. Zoe, we got a question about timelines as far as next steps. If you could tackle that one, that would be great. And also a question about the differences between draft 1 and draft 2, which is also a question we got.
Sure. So this is the second draft of the TEFCA, including the Trust Exchange Framework, the minimum required terms and conditions, or MRTCs, and then the QHIN Technical Framework, or QTF. So we, as John mentioned, we concurrently issued a notice of funding opportunity to select an RCE to help us develop the additional required terms and conditions that will go towards finalizing the common agreement and updating and finalizing the QHIN Technical Framework. So we will be selecting an RCE and awarding an entity in the August timeframe, at which point we will begin working on the ARTCs and finalizing the common agreement. We will then release another version of the full common agreement for another round of public comment, and then we will finalize the common agreement for production. And once the common agreement has been finalized for production, at that point we will begin to take applications for QHINs and begin to designate QHINs.
Thank you.
Hey, John, not to cut in, but I just wanted to say one other thing about the QHIN technical framework. So this is not in relation to the question that Zoe just answered, but some of the other questions we've received. One of the things that we'll note is that the QHIN technical framework is really describing the standards and specifications, the technical and functional requirements for exchange between QHINs. And there's a subtle nuance here that the information exchange within a QHIN's own network isn't necessarily being constrained by the QHIN technical framework. And so those QHINs are free to use whichever data formats or standards that meet their business needs, so long as they can meet the functional and technical requirements of the QHIN exchange, the QHIN technical framework, and exchange information in a standardized way between QHINs. So if a QHIN does internally use a different data format or standard, they might have to convert to the data format or standard that's specified in the technical framework when sharing with another QHIN. But we're not precluding the use of those other standards and specifications.
Excellent. Thank you, Alex. Zoe, we got a question about the TEF, the principles that are included in there, and if those have binding authority over the QHIN.
Yeah, great question. So the Trusted Exchange Framework just consists of principles for how health information networks should behave in order to enable a trusted exchange. These are non-binding principles, but they're more like rules of the road and guidelines for how health information networks should behave. You'll notice that we don't use a lot of the same terminology in the TEF, like we don't talk about QHINs or MRTCs or the RCE. And in fact, you might even notice that we refer to an individual with a lowercase I as opposed to a capital I, because we're not referring to our definition of individual, which is somewhat more expansive in the MRTC.
Thank you, Zoe. We also had a question about which data would be required to be shared via the network, if it's the US CDI or broader. Zoe, if you can handle that one.
Yeah, absolutely. So section 2.1.1, or sorry, 2.2.1, 7.1, and 8.1 specify the operations for how QHINs participants and participant members need to respond to queries and initiate, other exchange purposes. And so it does specifically say that queries should be responded to with all of the electronic health information in the USCDI that you have available. So there's sort of two caveats there. It's the USCDI information, and then again, it's what you have available. If you don't have the data, then you don't need to send the data.
Thanks, Zoe. Next, we've got several different questions that are sort of a variation on this, but how many QHINs do you expect there to be, Steve?
John ordained me for that answer. So, we know that there are a number of health information networks or health information exchanges, as they go by another name in some cases, that are out there that are capable of performing a lot of the functions that we've included in the marriage between the minimum required terms and conditions and the QHIN technical framework. We don't have a specific set number of qualified health information networks. And as Zoe mentioned in her earlier remarks, it's really a consideration for those health information networks, just to use that term consistently, as to whether or not they want to step up and be able to serve as gateways and single connection points to other QHIN qualified health information networks throughout the nation. So I think it's not going to be thousands, may not even be hundreds. But there are certainly a good number that could step up and perform these functions, and we would very much encourage them to take a look at what are included both from the policy requirements as well as the illustrative, first draft that we included in the QHIN technical framework, and give everybody feedback on that.
Thanks, Steve. Zoe, I'll turn to you with this one, which came in, which was about meaningful choice, and can it be done more granularly than complete inclusion or not?
Sure, although I might defer to Steve and Alex there on some of the technical requirements for doing it more granularly. Currently, as it is proposed in the MRTC's, meaningful choice would be a blanket opt-out, if you will, of having all of the data exchanged through the network. It's possible that in updated versions of the QTF, we may include more granular standards for doing that and for segmenting the data. So we do have a request for comment in the introduction section of the TEFCA that asks about possible approaches or standards for doing confidentiality codes and security tagging, et cetera.
So for the next question, I'll turn to our OTEC colleagues, which was about the QTF. And the question was about what are the requirements on the QHINs to offer RLS services or EMPI services?
Yeah, that's a good question. And at least in the first draft of the technical framework, we did not impose specific standards-based requirements on QHINs. So there are functional capabilities that a QHIN will have to meet, which are, just your very essential being able to match patients and then find where their records are. However, we're aware that there are different ways to do this, different approaches in the industry today. It might be a little bit easier to do patient matching record location with some sort of centralized enterprise MPI or RLS, record locator service. But as of now, we're not specifically imposing a requirement on QHINs to implement that type of infrastructure. Rather, they just have to meet the capability to find patients and their records.
Yeah, and to piggyback just a bit on Alex's point, certainly you can come out with very explicit requirements and dictate the only way that things should be done. But we have lots of experience and feedback from the first version of the Trusted Exchange Framework comments that there were certain areas where specificity around the functional capabilities that QHINs needed to perform were important for industry consistency and exchange between the different QHINs, but that we should allow for innovation and competition around particular services and how those services are actually performed. And so that's where you see us try to strike that balance in providing clarity of function for qualified health information networks, but allowing for them, even, as the existing point that I think Zoe and Alex both made earlier, we're starting with the perspective that there are health information networks already, and they're probably doing a lot of these things, and we don't need to tell them how to do that better. We need to just identify, if you're going to do this at a nationwide level, here are the other kind of extra capabilities that you need to make sure you can do in order to communicate with other QHINs like you.
Thank you. So the next question was about non-HIPAA entities that are connected to the network and what are the requirements that are placed on that. And I don't know if Morris is on or if Mike, or if we lost you, or if Mike can take this one, or Zoe.
Yeah, no, I can take it.
Mike, yeah.
Yeah, and I touched on this a little bit before when we talked about the applicable law. So first of all, the common agreement is structured in such a way to be inclusive of all types of entities, including non-HIPAA entities. And so we have identified in the MRTCs certain protections and requirements that would apply to all participating entities and not just those that are, HIPAA covered entities or business associates. So in some cases, those protections mirror some of the HIPAA protections that are already in place. So, for example, minimum necessary requirements and breach notification requirements are two examples that extend directly to all of the participating entities in the common agreement. Then we also have certain provisions that they're not exactly the HIPAA provisions, but may mirror HIPAA provisions. So, all participating entities that provide services to individuals have to provide individuals with a written privacy summary explaining their privacy practices. And this is, similar to a notice of privacy practice requirement in HIPAA. We also have a requirement that all participating entities that are providing individual access services provide a summary of disclosures to individuals upon request, which again, this is similar to the accounting of disclosure requirement in HIPAA. But we do have a request for comment, and we're really looking forward to comment on what additional privacy and security protections should be included for non-HIPAA entities that are participating in the TEFCA.
Thank you, Zoe. So I'll go back actually to you, Zoe. We got another question, which was, and I apologize, I'm not finding it specifically in the queue here, but I remember the essence of it, which was about the exchange purposes only applying to CEs or BAs. Can you explain how that works to folks?
Sure. So some of the exchange purposes, not all of them, but certain ones like treatment, quality assessment and improvement, business planning and development, and utilization review are defined per the definitions that are in HIPAA. So we have not expanded those exchange purposes to apply to non-HIPAA entities or even all electronic health information. So for those specific purposes, at least for now, those ones are confined to current HIPAA covered entities and business associates. Now, we plan to work with the RCE and with the industry to phase in additional requirements and to phase in, additional opportunities for others within the network to use these purposes. But we kind of wanted to start off crawling before we walk, and making sure that even as we are expanding access to EHI and expanding interoperability, we're not doing so at the risk of going too fast and potentially disrupting current exchange initiatives.
Thanks, Zoe. I'll have another one for you, but we only have a few minutes, and we had a lot of questions that we weren't able to get to, and really appreciate the various questions. It's really helpful for us to see where folks are thinking, but I think we got to most of them, actually. There was a question in here about do the TEFCA standards support a QHIN being able to facilitate direct-to-patient individual access services? And the answer is yes. And so I encourage you to look at the minimum required terms and conditions sections on the Qualified Health Information Network requirements. So we got to that one. But then there was another one that was asked, Zoe, about whether folks can go above the requirements that are built into HIPAA. How does that work, and what would that look like for a service provider that's looking to offer something that adds on to the requirements of TEFCA or the services that we're talking about enabling by the network?
Absolutely, that's a great question. I'm glad that we got to that one. So there is nothing that prevents QHIN's participants and participant members from going above and beyond and offering more services and more exchange purposes than what's in the common agreement, as long as nothing conflicts with or limits something that they're required to do per the common agreement. And so we anticipate that entities are going to have to modify or develop new participation and data use agreements that incorporate the terms and conditions from the common agreement. So, for example, participants will have to modify their current data use agreements to include the participant member obligations that are found in Section 7 of the MRTC. As in this modified agreement, they could include additional terms and conditions that allow for these services above and beyond within the MRTCs, as long, again, as it doesn't conflict with the terms and conditions of the common agreement.
Zoe, thank you. And I want to thank everybody again for their participation in the call today, all of the excellent questions. I want to reemphasize that we ask that folks please submit comments officially to our website, healthit.gov/TEFCA. And also for those entities well, everyone should be familiar with the requirements in the NOFO, but for those entities that are eligible, to please apply, and you can find the notice of funding opportunity on this website and apply via grants.gov. The link is all through there. Thank you all so much again, and everyone have a wonderful day.